Hello and welcome everyone. Today we are discussing about the medication errors that we have in the ICU. So what is the definition? Medication errors are any kind of preventable mistakes which can be either in prescribing, dispensing or giving the medications. In ICU, the medication errors are the most common patient safety incidents that are happening. So it is around 60% of all the reported errors. ICU patients are at a 5 times higher risk of medication errors compared to non-ICU patients. So anyone working in the ICU must have seen that there are a lot of medication errors which are happening. Most of them very mild and not very serious, but definitely some can go on and become fatal also. Regarding the prevalence, the rates vary widely based on the method by which it is detected. Self-reporting is one of the most common methods where we find around 6% of ICU patients getting affected with medication errors. External review of the record, 92% of the ICU patients have some medication errors. Prospective pharmacist observation has detected around 25% of medication errors in high risk drugs. Regarding the incidence, the range is again very high, from as less as 6.8 to up to 4,995 episodes of medication errors per 1,000 patient days. Now 3.4 to 27 medication errors occur every 100 prescriptions. Adverse drug events, these events leading to adverse effect is seen in around 1 to 150 per 1,000 patient days and 0.15 to zero point 0.1 for every 100 prescriptions. So by no means this is a very small event or a rare event. It's a very common event which is happening very frequently in our ICUs. Now stages where these errors can occur are the prescription stage, where you can put a wrong drug or a wrong dosage or a wrong frequency. The next is the dispensing stage, where you can do a wrong medicine preparation or labeling. The next is the administration stage, where you give it to the wrong patient or in a wrong time via wrong route. Next is the inadequate drug monitoring or dosing, which may happen in cases of liver or renal failure. So this figure basically shows the common points where the medication errors can occur in the ICU and the strategies to prevent them. As we've already discussed, the first point where the error can occur is the prescription stage, where you can do all these things like incorrect dosage, wrong interactions, wrong medications, long routes, inadequate duration. Now prevention is, you can do it by e-prescribing methods, where the medication review and reconciliation by pharmacists can be done online, reduced shift duration for prescribers, critical incident reporting systems. These all can help you in mitigating this risk factor. The next is the dispensing stage, where you can reduce it by having an automated dispensing system, but then everything can have errors. But when you have some major errors, you should have some system like a critical incident reporting system, because these type of errors should not be overlooked. In preparation stage, you can make wrong preparations, which obviously will need more training of the staff to overcome. Then is administration, wrong infusion rate, dose omissions, wrong time of administration, everything has to be kept in mind. Prevention is again pharmacist supervision, education and clinical guidelines. Finally is monitoring. You have to monitor the physiological state, the renal and the liver function and various other things. So high risk drug classes where you will find higher chances of these type of problems are sedatives, that is midazolam and propofol, antimicrobials, vasopressors, anticoagulants, insulin. Now, patient related factors are severe illness, emergency ICU admissions, older age group, longer ICU stay, renal dysfunction. So, basically, as you can see, these things make the workload on the people very high, because you have a lot of medications going on, a lot of things going on with the patient, polypharmacy. So keeping everything in mind becomes a little problematic, and people tend to make error when these type of factors are there. The next is the staff related factors, that is a lack of proper training and education, the inexperience of the clinicians, fatigue and stress, that is sleep deprivation, adjusting the work patterns and reducing the sleep loss has shown to reduce the medication errors by as much as 21%. Next would be the organizational risk factors like workload, the time pressure, the interruptions, poor staff allocations, inadequate documentation, high patient to nurse ratio, poor communication between the staff, that is doctors, the nurses, and the pharmacists, frequent staff changes and transfer of care that again makes a lot of problem. Finally, missing medication levels that will make life very difficult. So these are all organizational issues. So the management people, the doctors who are, and nurses who are working in management positions, they must keep this thing in mind, check for these errors, and try to mitigate them. Special situations are like contact isolation linked to more errors with anticoagulation and insulin. Patient transfers will increase the risk. 74% higher adverse drug reaction risk during transfer. And 46% of the patients at ICU discharge had some kind of a medication error, often inappropriate continuation of the ICU, only medications like stress prophylaxis and antipsychotics. So, as you can see, the points of where these errors are occurring are usually transfers, where the care is not taken to stop a particular medication or restart a particular medication which would be appropriate for that particular area. Clinical application, the double check of high risks is vital before any kind of an administration. Adjust dosages for liver and renal dysfunction. Ensure proper labeling of all medications and proper documentation for all kind of prescriptions. Minimize the distractions during preparation of medications and administration. This is something which the ICU nursing in charge must keep in mind, to make sure that the nurses are not getting distracted with other works. It's not that there will not be work, there will be some work. They must ensure that and make sure that the administration time and the preparation time, the nurse is not distracted with other kind of activities. If that is happening, then it is bound for them to make some kind of an error here or there. Improve the handover quality during transfer. This is critical, as we have already seen. It is during these transfers that the patients tend to get more prone to medication errors. And obviously maintain adequate ratios, which is the baseline for everything. So how the impact is measured usually of this mechanical medicine error? Different studies have used a classification system to grade the harm that has been caused by medication error. Some have used scores like no harm to C, like, and patient death as I. So various categories have been made. Clinical impact like organ damage, extra cost that was added, perceived severity which was significant to even fatal, medication change severity like trivial to major. Now, role of human factors, staff related factors are very important and play a big role in causing the medication error and adverse drug reaction. No studies have looked at the emotional stress on the ICU staff after a medication error. This has to be kept in mind, because no person actually makes an error just because they want to. No one is working like that. Everyone wants to do a error-free work, but unfortunately, as we have seen, there are various factors here. A lot of work is going on, so many of the time the staff inadvertently get into these errors. So what is the impact of these errors on them? That must also be kept in mind, rather than just blaming them for the error and saying that it was their lack of education. Degree of the patient harm has to be kept in mind. In the end, we have to keep in mind we all are working for the patient, so finally the patient must not suffer whatever must be happening. However, most of the medication error do not do harm. However, that is because they are caught before the act happens on the patient. But then that's not always the case. Pharmacists and nurses often intercept high risk prescribing errors. 95% of the medication errors are no or minor harm. Uh, but then that must not be overlooked, because serious and life-threatening harm do occur in 1 to 5% of medication errors. Now, this is the data which is coming from all over the world. It's not that this is coming only from low-income countries or high-income countries. It's standard and all over the world. So it's everyone must work together, because irrespective of the economic status of the country or the patient, it is ultimately the patient who is suffering, and it is the duty of the doctors and the nurses and the medical staff like pharmacists to prevent these errors. Mortality from medication error is rare, mostly zero in most of the studies, but then that is expected. No one is going to actually report these deaths, because this is never something which anyone is going to agree to. But then we must keep in mind that these things can happen, and they do happen, and they should not happen, and they should not be blamed on anyone. It is the system which is failing. That is why this thing is happening. So the whole point of view is to make sure that none of these harms actually reach the patient. So our pre-patient check are so strong that these errors, even though they are happening, are never transmitted onto the patient. One study found 7% mortality in adverse drug reaction of patients, but often adjusted after adjusting for the age and organ failure. The adverse drug reaction was not linked to higher ICU mortality. That is expected, but then that's statistics is just one aspect of the thing. It doesn't mean that we should give importance to all these things and neglect the need to find out these errors and stop these errors. 73% of the studies show these errors increase ICU and hospital stay. No study has measured exact cost impact, but longer stay mean higher cost. That's quite obvious. No harm case like nurse notices a wrong insulin dosage before giving, corrects it, no harm done. This is a very simple thing that happens. Minor harm is like severe sedation dose given, so the patient was drowsy for a longer period of time. This may not have an immediate impact on mortality, but this thing happens repeatedly, making the patient's weaning difficult, and ultimately the patient goes on to a tracheostomy or fails to extubate. Then that becomes a major problem. A major harm is when wrong dose of anticoagulation is given and patient has a significant bleeding. Organization loss is wrong antibiotic choice, delays infection control, ICU stays extended by days because of these issues. Now, if we want to control all these things, let's first find out what are the major risk factors of these medication errors. As we have already discussed, the patient related factors are the high severity of illness, the emergency ICU admissions, and the older age group. So a lot of work is going on. The clinical context is important, where you see that there is renal or liver dysfunction, prolonged ICU stay, and isolated cubicles where you do not have much help. Transfer of care, a major place where we are having errors, because the handovers need to be much more stronger. High risk medications, because these medications, even a small change can make a big impact. Environmental interruption to the working, lack of medication labels. Finally, you have the organization, that is role overload, reduced staff levels, inappropriate staff allocation, frequent staff changes. And then we have staff related, who are in fatigue, sleep deprived and stressed, so they can't work properly. And last but not the least is the education, where there is lack of training on protocols and staffs are inexperienced. Now, type of studies evaluating the interventions to prevent these are many. Most of the studies have been observational or with a before-after design. Few randomized trials have been done. There is one RCT, one randomized time series trial, one cluster randomized trial. Some studies simply identified existing good practice that help reduce medication errors. Key interventions shown to reduce the medication errors are the pharmacist's involvement, medication reconciliation, that is matching patients' prior medication with the new ICU order. So, medication reconciliation is a frequent problem which we see in our ICUs where the patient's prior medications are completely ignored and new medication charts are made, and then the patient is totally confused after ICU discharge what they should be taking because they have a complete separate set of instructions for them. Medication review during ward rounds is very important. Make sure that these things are looked into in every round. Direct participation in multi-professional rounds is vital because pharmacists' involvement is very important over here. They must ensure that proper dosage is being given and patients' drugs which are over lapping with each other should be removed. Pharmacist catches high dose vasopressor dose in renal failure cases and corrects it beforehand. So in this multi-professional round, the presence of a pharmacist becomes very critical. Regarding e-prescribing, especially effective when paired with clinical decision support because you need some kind of a support and then the prescription help which will help you in reducing the medication errors. Automated medication dispensing systems, they reduce the dispensing errors because they are barcoded and they have a locking system. But then in the end, as you can understand, every system can have some kind of a human error creeping in. The barcode has to be fixed by someone manually after all, or at every point there is will be some kind of a human interaction, and that point can be a potential source of error. So we cannot say that every step can be made computerized or totally made human free. Reducing the medical staff work hours, that is a management task, so they must make sure that it happens so the patient the nurses are less fatigued, the doctors are less fatigued, so there is less error while prescribing. Regarding timeouts, pausing during ICU rounds to review all active medication for appropriateness is very important. Don't get so carried away with the patient's prognosis, what the probable diagnosis is, that you have completely forgot about what actual drugs you are giving to treat the patient. Multifaceted programs, staff education, standard care guidelines, audit, feedback, standardized infusion levels, pumps to avoid mix-up, all these things should be kept in mind. Intervention proven to reduce the actual patient harm are e-prescribing with decision support, pharmacist-led medication reconciliation and review, medication review timeouts, and other practices like critical incident reporting system for medication errors, clinical decision support alerts with e-prescribing systems. All these things will help you reduce your medication errors. So where in the process this intervention work? Prescription phase is the most important part. This is the major target because this is way away from the patient. So the faster we catch it away from the patient, the better it is for reducing the error and its impact and the harm that it is going to cause. So 55% of the intervention target the prescription phase, and this has to be the most important phase. If this phase is properly checked and properly overviewed, then we can reduce a lot of harm to the patient. Administration phase, already a very advanced stage. It will require advanced vigilance from the people who are at the bedside. The in charges and the doctors at the bedside must be very, very attentive and careful before, so that errors don't happen over here. Dispensing error, this is something which happens at the pharmacy level. If you have automated system, you will definitely reduce the problems, but then as I have said, you can't make every step human free. Entire medication process obviously needs to be overlooked, so a holistic safety program must be kept in mind. Transition of care, that is shifting of the patients, handovers have to be very, very properly and meticulously done. Medication errors and preventable drug errors are common in ICU and affect many patients. Risk is high because ICU patients receive more high-risk drugs and often require complex dosing and may have organ dysfunctions, which changes the drug handling. Error most often occur during prescription, dispensing, and during the administration. Most medication errors are caught before the harm occurs, but some still reach the patient and can cause harm. So this happens because as you stay longer in the ICU, the more chances that you will develop something like this is going to increase. And if it happens, your healthcare cost will also increase. So why the rates vary so much is because of the large variation in reported incidents due to different studies designs and methods to detect these errors. Prospective direct observation is most sensitive, but then you will be extremely resource challenged over here. True rate is hard to determine, making meta-analysis extremely challenging. High risk situation and population, because this work is continuously happening in the ICU. So it is difficult to have someone posted during that critical moment. To just overlook everything is very labor intensive and resource intensive. Transition is somewhere which is very risky and can be handled properly if there is proper handover and there is less time pressure and better prescription systems. Patients with renal dysfunction or in isolation are at higher risk. ICU to ward transfer often see inappropriate continuation or omission of medications. Interventions that work best are e-prescribing, as we have already said, medicine reconciliation, clinical pharmacist involvement in daily rounds, multifaceted approaches like staff education, guidelines, audits, and feedbacks. This will reduce your medication errors and prevent the patient harm. So be cautious of technology. Technology is not something which will definitely help you in all aspects. It has to be kept in mind that this can also create errors. New systems can create new types of errors like wrong drug selection in drop-down menus. Staff may bypass and override safety alerts if poorly integrated into workflow. So see, if you have a lot of workflow, the staff is going to definitely going to bypass. They are not going to spend hours just because you have made an online system for prescribing. So this is what has to be kept in mind. The workflow has to be smooth. It has to be smooth enough that you have both things. That is, it is taking care of the flow, that the work is also getting done properly, as well as making safety. Just for safety, if you are putting a lot of checks, the staff are going to get fed up and the workflow is going to get increased and they are going to bypass all the necessary questions that you are asking. Implementation must consider human factors, which is very important, training and ongoing monitoring. Regarding the future detection, more high quality prospective trials are needed with direct observation, but then that will require a lot of intense funding and a person to actually oversee the work that's being done. Focus on high risk patient group and transition points, explore the emotional impact on the staff and ways to support them when such a serious error does happen. Consider environmental impact of the medication error, like throwing away the waste in places where it is not to be disposed. This has to be kept in mind. Expand the use of AI and closed loop systems. Ensure safety, trust and regulation. The limitation of current evidence is that most of the studies are from high income countries, limiting generalizability to low and middle income countries where the medication errors tend to be more severe. Definition and detection methods vary, making the prevalence estimate uncertain. The bottom line for practice is that medication error in ICU is common, but it is preventable. Though it rarely causes death, but it can increase your ICU stay and hospital stay, but it has to be prevented. Prevention requires technology, human oversight, and a system improvement. It cannot just happen by saying that a staff is negligent or there is just generalized lack of education and educating will solve these problems. No, that's not going to happen. You have to combine everything. You have to combine the technology. You have to make sure that everyone, the bedside staff, the in charge level, nurses, doctors, everyone is focused on preventing these errors. And finally, the system has to work together. Here, the role of pharmacists becomes very important. Medication reconciliation is being emphasized repeatedly and should be done always. Decision support system should be made so that the decisions are made fast and so that a lot of time is not wasted in those things. Thank you for your patience.